Dr. Colvin, we were in December 1984, and just a couple more documents, or three more documents from late 94, early 95 to look at. BART 0000519. So, again, this is a document you've seen only this morning, Dr. Colvin, since you wrote it, obviously, many years ago. 20th of December 1984, you're writing to Dr. Harrison at the Regional Transfusion Centre. And it says this, Dear Jean, at your request, I'm writing to confirm that I'm willing to continue to use non-heat-treated NHS concentrate for the time being. This decision is, of course, in accordance with the discussions which took place at the recent Regional Working Party on Haemophilia. And then you say you look forward to receiving heat-treated NHS concentrate as soon as it's widely available. We'll take it in stages as we go through the correspondence. But can you recall, first of all, why you were being asked by Dr. Harrison to give this confirmation?
No, I can't.
You're setting out there a willingness to continue to use non-heat-treated NHS concentrate in circumstances where we know that the recommendation now from UKHCGO is to use heat-treated concentrate in preference to unheated concentrate. Why was that?
I've already explained, I think, that I was not confident that heat-treated concentrate would, in fact, prevent HIV infection, and that if it didn't, then all my patients who were HIV negative would become HIV positive. And so, as I've explained, this was an absolutely impossible situation in which to place ourselves. I believe that from this letter, that the decisions that took place at the Regional Working Party allowed me to take that action, and I think Peter Colvin and I worked together very closely to try to construct a rational policy. I've also confirmed, as we know, that heat-treated commercial concentrate was still transmitting HIV in 1986-87.
Although you didn't know that, obviously, at the time.
No, of course I didn't. But I knew that HCV, or at least non-A B, was not necessarily being eliminated by the heat treatment processes that were being used at the time. And I've also, I think I'll confirm it again, that the safety of a concentrate depends on the donor pool, the way it's been selected, the size of that donor pool, and the level of viral activation. And those changed quite a lot over the period of 2 years that led up to the final safety of product by 1988.
And just on the issue of size of donor pool, do you recall what you knew at the time about any the relative difference in sizes between NHS and commercial concentrates? No,
I can't recall that detail.
And then if we go, please, to BART 0000524. We can see that this is not long after that last letter. It's a letter from Dr. Harrison, dear colleague, 2nd of January 85. It says, following further discussions between myself and Drs. Kernoff and Colvin, it has been decided that, in the light of recent findings reported in both the lay and medical press, non-heat-treated NHS Factor 8 concentrate will not be used in the North East Thames region after current stocks are exhausted. So, is it right that there was further discussion after that last letter between you, Dr. Kernoff, and Dr. Harrison?
Of course, I have no recollection.
That would seem a fair inference to draw from the correspondence.
It looks as though that's. I mean, it's what is written is written.
Do you know what the reference is to findings reported in both the lay and medical press?
No, I don't.
And then we can see there the proposal now is you won't use NHS factor concentrate in the region after the current stocks are exhausted. So you will use up what you have of non-heat treated NHS and then presumably move to heat treated or others.
That's what it says.
And then if we look at BART 0000526, this is a letter from you to the District Treasurer and the Finance Department at the London Hospital, 28th of January 1985. And we can just look at the second paragraph. You said, as I indicated in a previous letter, we have reasonable supplies of non-heat treated National Health Service concentrate at the moment, which should last us for another 2 or 3 months. As noted in Mr. Knight's letter, we will then have to buy commercial heat treated concentrate unless by that time heat treated NHS concentrate has begun to become available. So it would look from this as though, in terms of the treatments you were using in the first few months of 1985, your proposal, your intention was to use up the current stocks or supplies of NHS concentrate, not heat-treated concentrate, which might take you to approximately April of 1985.
That's the implication.
And at that point, you would then either have product from Elstree that's heat-treated or you'd buy commercial products.
That's the implication.
And as far as you recall, is that what happened? Or,
I have no recollection.
what consideration did you give, or do you think you would have given at this point in time, to the fact that, notwithstanding the concerns you've expressed, the clear recommendation by this stage from UK HCGO was to prefer heat-treated over non-heat-treated?
Well, I can only assume that Peter and I didn't agree with it.
And then if we go on to, please, BART 0000675. This is a meeting now in May of 1985 of the Haemophilia Working Party of the North East Thames region. And we can see again that you and Dr. Kernoff are there. If we go to the second page, we pick it up in the bottom half of the page under the heading Factor VIII Concentrate Heat Treatment and Supply. We can see the position there set out as at May of 1985. The requirement that all Factor VIII concentrates should be heat-treated means that more commercial product is being used than before, with the attendant risk of hepatitis B and non-A, non-B hepatitis transmission. And then there's reference to pilot samples of the NHS product being effective. There's a report in the next paragraph of from trial users of the newer NHS dry-heated product. And then it says this: when sufficient is available, this product will be the first choice for all newly diagnosed patients, children and others not yet exposed to the HTLV3 virus, and will replace cryoprecipitate as the preferred treatment in appropriate cases. The USA experience confirms that cryoprecipitate has caused less hepatitis and HTLV3 antibody seroconversion related to the small pool donations and the fact that cryoprecipitate is prepared from the plasma of volunteer donors, unlike large pool commercial Factor VIII concentrate, which is chiefly from paid donations. And then at the top of the next page, it said Dr. Colvin proposes to replace the use of cryoprecipitate by NHS heat-treated Factor VIII concentrate as soon as possible. In the meantime, patients requiring infrequent treatment should continue on DDAVP and cryoprecipitate. So it would appear from this that by May of 1985, you're using DDAVP, you're using cryoprecipitate, and you're using commercial heat-treated products, or the region at least is using commercial heat-treated products. The intention is to start using the NHS heat-treated product subject to availability.
I can't remember when the AY study starts. It must have been around 84, 85. I'll have to look to see when the AY study started. But I was committed, as ever, to NHS activity, and I contributed, as we probably discussed later, to the AY study. Probably by the time we get to this paragraph, I am personally convinced of the safety of 8Y, although it hasn't been published and I can't be sure. And the proposal to replace the use of cryoprecipitate by 8Y seems appropriate to me at that point, I think.
Now, in your statement, Dr. Colvin, you said in relation to the question of reverting to cryoprecipitate, that you didn't believe that reversion to cryoprecipitate for all patients in all circumstances was ever a realistic choice. We've obviously touched on this to some extent, but can I invite you to just summarise why you say cryoprecipitate for all patients in all circumstances was not a realistic choice?
Okay, so I've already indicated that I did use cryoprecipitate for small children and also for the selected patients that I discussed in the paper we looked at yesterday. I also explained that cryoprecipitate is allergenic. I also explained that cryoprecipitate is a single dose preparation whose actual dose is not known, and that if you used 10 bags of cryoprecipitate for one treatment, that would be 10 patient exposures. That supply was not unlimited, contrary to what has been said elsewhere, and that the material was difficult to make up, and that certainly at night it would be extremely difficult to deliver 8-hourly treatment in using cryoprecipitate in that way. So I think all this is rehearsing material we've dealt with before, and it is the case that I never believed that cryoprecipitate could be used in all circumstances for all patients.
If one moves back from all patients, all circumstances, what about reversion to cryoprecipitate in response to the AIDS crisis from January 83 onwards, say? What about reversion to cryoprecipitate for a much larger cohort of patients than you did?
Well, there's nothing I can say, really.
Would you accept that would have been possible?
I don't know.
What are the factors that bring in uncertainty? Supply?
How much cryoprecipitate was available? How much we could arrange for material to be delivered to us? How much difficulty there would be in training people to do something that was extremely old-fashioned? How to persuade people to use very large syringes to deliver treatment that had been delivered in small syringes. I mean, a whole host of logistic aspects. But I don't think it ever actually occurred to me to do such a thing.
And so those logistical difficulties, that's, I think, one of the phrases you use in your statement, in fact, were not explored at the time. You didn't ask the questions that you've just posed about whether you could get the supplies, how you could do the training, because, as you've just said, it didn't occur to you as an option at the time.
I didn't think it was realistic.
But did you explore the practical realities with Dr. Harrison or others?
I don't recall.
What about the option of offering cryoprecipitate on an individual basis to your patients, explaining the pros and cons, as you have done to the inquiry, and leaving the choice with the patient? Did that occur as a option?
No.
Do you think it should have done?
No.
Why?
Because I don't think it was realistic. I really don't think that this was a realistic option. I don't think anybody that I knew ever thought that to go back to using cryoprecipitate for everybody in all circumstances of this position was realistic.
Forgive me, Dr. Colvin, I understand your answer to all patients, all circumstances. So what I'm inviting you to consider now is you could have sat down with individual patients, explained to them the risk of HIV, explain to them your view of the disadvantages of cryoprecipitate, but the advantage of, in terms of viral safety, and the disadvantages of concentrates in terms of viral safety, but its advantages in the other respects you've identified. And given them a choice, that wouldn't necessarily have led to every patient taking you up upon that. But
well, clearly I did do that for some patients. I've presented a paper, admittedly for only half a dozen patients, where that exactly happened. So it's a matter of what I could do at the time and what was realistic and what seemed sensible to me. And at this distance, I don't really think I can offer you any more detailed answers than the ones I've given.
Is it fair to say that it didn't occur to you to do this exercise of an individual conversation with every patient at the time?
That's fair.
And in terms of the categories of patients who you were during 1983 and 1984 treated with cryoprecipitate, leave aside the children who we've discussed. You've referred to there being some other patients who were being treated with cryoprecipitate, and we can see that from a number of the documents and from the study you referred to. Can you recall what the characteristics of those patients were? Other than children, how did you decide which patients to offer cryoprecipitate to?
Well, I think what happened was that there were a small number of patients with haemophilia or von Willebrand's disease that was not suitable for DDAVP, who were likely to require quite significant amounts of product and had not been treated much in the past, where it seemed to me that cryoprecipitate was a realistic option to cover a particular procedure that would otherwise use a moderate but not very large amount of material.
So it was based upon the particular individual circumstances of a limited number of patients.
Exactly.
If any patient had come to you, and I'm thinking particularly here of the 1983-1984 period, the concerns about AIDS, if any particular patient had come to you and requested to change their treatment from concentrate to cryoprecipitate, would you have acceded to that request?
I can't answer that question, really. I would always try to meet my patients' requests if I was able to do so. I can see that if a patient wanted to have cryoprecipitate on a particular occasion, I would certainly have considered it. If they wanted to go back onto home treatment with cryoprecipitate, I'm not sure that would have been possible. And I certainly wouldn't have recommended cryoprecipitate for major surgery.
And just dealing with home treatment, why would it not have been possible on an individual patient basis?
Well, I think it might have been possible on an individual basis. Nobody ever suggested it to me, and I never suggested it to a patient.
Can we then consider the question of what information was provided to patients about risks of HIV? First of all, would you agree that once we get to January 1983, the New England Journal of Medicine, we haven't looked, but there were reports in the national media in the early part of 1983, the meeting at London Airport with Immuno. Once that was known, that there was, at the very least, a very real risk that blood products could transmit AIDS, would you agree that patients needed to be told that?
I would expect that to be the case, yes.
And the purpose of telling them, would you agree, would be so that they could exercise a degree of choice as to whether to continue with their treatment or not?
Clearly, patient autonomy is important, so I accept what you say.
Because it would be it's ultimately it's their health if they don't have concentrates,
yes,
potentially
it's
their life.
It's a matter of consent, I agree.
Doing the best you can, Dr. Colvin, when do you think you began to tell patients about the risks of HIV?
Well, the answer is that I can't recall. Any comments that were made by me about this would be in the clinical notes of patients, and that's the only place really one could look for contemporaneous account of what happened.
I don't know whether you can answer this or not, Dr. Colvin. Do you think it more likely than not that you did tell your patients about the risks of HIV from early 1983 onwards?
I know that I spoke to some patients because I have a recall of speaking to some patients, but I can't recall, obviously, every patient. But there was certainly, during 83, 84, I was talking to patients about the risk of HIV, but I couldn't possibly tell you about each individual patient or whether there was a general policy of doing such a thing.
I think the example, or an example you give in your statement is having conversations with patients who were undergoing surgery or about to undergo surgery. In terms of the routine clinic appointments that you would have as I understand it, at least with your regularly treated patients, you'd have on every few months, you'd
Yes.
expect to be seeing patients. On those appointments, not for surgery, but to decide, to see how the patient is and plan their treatment for the next few months, do you think you would have told them then about the risks of HIV?
Well, it was in the press, and they would have had the opportunity to see that information, and I would have expected them to ask me and for me to speak to them about it. But whether I did or exactly when I did, it can only be a matter of record. And we're now looking at 35 years ago, and I can't make that kind of recollection.
Would you agree, this is as a matter of principle, as it were, rather than asking you to remember things you have indicated you don't remember, would you agree that one reason why it would have been important to share that information with patients is not only so that they could take their own decisions about treatment, but so that they could think about the safety of their close family?
Yes, I can see that point of view.
Do you recall having any conversations with, again, in 1983-84, this is before we get to the testing of your patients for HIV, any conversations with family members, spouses, about risks of HIV?
I have no particular recollection of such conversation.
And is this fair? If there'd been, as we've heard some descriptions in some centres of their group meetings being organised, if there'd been any kind of group meeting that you'd organised, would you expect to remember that?
The only group meeting I can remember was one that took place much later, when we did have such a group meeting. But I don't remember any group meetings at that time. Which is not to say there wasn't one, but I don't remember such a group meeting.
This is a hypothetical question, Dr. Colvin, in some respects, but I understand from your earlier answer that the best guide to whether you did spell this out to your patients at the time will be in your handwritten notes.
Exactly.
And so if they're not in the notes, the correct inference to draw is in relation to that patient, you didn't spell it out.
I think that's an impossible conclusion to draw. But I did try to take clear notes.
Well, can I press you a little on that? Because it's really about what your note-keeping habits would have been at the time. And I think you said yesterday that you regarded the keeping of accurate and comprehensive notes as important.
Indeed.
If you were telling your patients something as significant as, there is a risk that this treatment could, if you continue with it or if you start on it for a new patient, could bring with it a risk of what is understood to be, albeit imperfectly, a fatal condition. That's the kind of material that you would have included in your notes.
I would have expected to, yes.
Can I come on then to the process of the testing of your patients for HIV and them being informed of their diagnosis? We've seen reference, and indeed you've made reference to Dr. Tedder and the tests which he performed at the Middlesex. I understand from your statement that you had access to testing facilities through Dr. or Professor Collier.
Yes, that's true.
Who was a colleague at the London Hospital.
Yes.
So what, as far as you can recall, were the arrangements that you made for the testing of your patients for HIV?
I think I must have looked to see who I thought was at risk. And then we know that the virology department had stored samples of serum, which I had not controlled. I mean, they did that anyway, it was automatic. And Professor Collier decided that we could look at those samples. And I think he had a test of his own, actually. And I think he then referred his results to Dr. Tedder, probably for confirmation of what the results were. And then at that point, I decided to, once he was confident of the results, I decided to communicate that to my patients.
So, as I understand it from your statement and indeed evidence you've given elsewhere, you did not tell your patients that in advance that you were testing their sera for HIV.
That's correct.
We'll come on to why in a few minutes. In terms of the stored sera, you refer to communications with Professor Collier. Whose idea was it, if I can put it that way, to use the stored sera rather than asking for patients to come in and give fresh samples?
I imagine Professor Colvin and I decided to do it together, but I don't remember whose idea it was.
Do you know or have any idea, I don't expect you to remember specifics of dates for individual patients, but do you know when these stored sera would have been stored? Because if you've got someone and it's sera stored from 2 years ago, it's going to tell you if they were HDLV3 positive 2 years ago, but not whether they've subsequently seroconverted.
Well, we did know there were such samples, yes.
These were recent samples.
There were some, I mean, it's every 3 months or so that they would be seen, and then they would automatically go down into the store. So I think that the point you're making, I think, is there may have been some samples that went down at the time of testing. But I think that the situation was different at this time to the time later, when, of course, there were still people who didn't know whether they were HIV positive or not at a later time, and then they would have, I think, been asked if they were happy for their samples to be tested. We're talking now about the crisis when there were probably 80 patients who potentially might have been infected, and that was a problem that needed to be managed at that time.
And just dealing, if I may, with the stored samples. So a sample was taken at every clinic appointment.
Yes.
A spare sample, as it were, that was stored.
Well, I wouldn't say it was spare. I think it was the virology department and maybe the chemistry department. I'm not sure who stored the samples where, but I think every time we did anything that produced serum, it got stored.
But as
it wasn't spare exactly.
Well, you took the. You would take bloods
yes.
on a routine clinic
yes.
appointment for a range of tests that were going to be done there and then, as it
yes.
were, ALT
yes.
tests, the liver function tests. This is a sample that you were keeping, not to test at that point in time, but in case it might need to be tested at some point in the future.
I guess so. I mean, I don't think I was involved in the process of keeping samples. I didn't say, please keep this sample particularly. I mean, my memory, it's a very long time ago, was that this was what happened.
Okay. And just, I know you told us yesterday about how when you first started out, you could actually do quite a lot of the testing yourself. You had, as it were, the skills that you'd learnt on the job in the 70s. By the time we get to 1983, 1984, where physically did the blood get taken from the patient and who by?
Yes, well, once we knew about the HIV risk and we had reacted to it, and I'm not sure exactly when that was, as you may come on later, there was a discussion about high-risk labelling. And once that high-risk labelling came into play, then I arranged that all my samples would be labelled by me before I went down to the clinic, and then my nursing staff took all the samples themselves so that patients didn't have to go down to the phlebotomy department to have their blood taken. But exactly when that happened, I don't recall, but I do recall extremely clearly arranging that all the requests would be written out by me and that the nursing staff would take the bloods.
And we'll come on to the question of what the applicable standard might have been at the time, but why didn't you tell patients that their blood was going to be tested for HDLV3?
I can't answer that question really, because I think what we did was to recognise the need for the samples to be tested, that there were 80 samples probably that needed to be sorted out, which was a very large number for a very small service, and that I must have felt at the time that that was the only way to proceed. It's important to appreciate that the mindset of a haematologist is, as Mark Winter was explaining, that one is both a physician and a pathologist, and that the purpose of being there at all is to address a clinical problem and to solve it. And the advent of testing meant that finally we had some kind of handle on what on earth was happening. And at the time, although of course things changed very much in the later part of the 80s, it wouldn't necessarily, and I don't think it particularly did occur to me, that there was something very special about the anti-HTLV3 test that was different from any other blood test. And maybe that mindset was a wrong one, but it was a view that I think was very widely held in the haemophilia treating community. And we felt that we needed to get on to do this work. Let's say for a moment, at the end of 84 or the early 85, I had brought up 80 patients, one way or another, to discuss with them whether we were going to test their blood, because it needed to be done quickly. There wasn't a question of waiting for the next 3-month appointment. They would then have been brought up to see me, and I would have said, we have this test which we think is now valid, but we're not sure because there were false positives and false negatives. We can arrange for your blood to be tested, but it'll take at least 2 or 3 weeks for the results to come through. And when the results do come through, we'll call you all up again to deliver the message. I wouldn't have wanted the patients to have telephoned me for the answer. I wouldn't have wanted to write to them with the answer. What would have happened would have been that over quite a long period of time, 80 patients would have had to come to see me, had their blood tested, spent 2 weeks worrying about what was going to happen next, and then had to be brought all the way back again, often from far away in Essex, to be given the answer. Now, maybe that was the right thing for us to have done, but I think it would have been extremely difficult.
Because the converse position, as has been described to the inquiry by some patients, not necessarily patients of yours, Dr. Colvin, I can't recall whose patients they might have been, but the converse, some have described the sense of shock at being told that they have HTLV3 in circumstances where they didn't even know they were being tested for it. I
can understand that. What I can say is that whichever way you look at it, there was going to be a huge sense of shock. I mean, let's say we'd done what I just said, of bringing 80 people up, testing them, bringing the 80 people up again, and then telling them they still have terrible, terrible shock, and it would be extremely difficult to avoid giving information on the telephone or by letter before they came to see me in person. So that really the situation was terrible whichever way you looked at it. I'd also say, and I know this isn't in a way perhaps evidence, that nobody ever said to me in that period that they wished that I had asked their consent before testing their blood and giving them the information. I believe I gave every patient the information personally, and I don't believe that any patient of mine ever complained at the time that they hadn't been treated properly.
And in terms of the telling patients the test results, did you only tell patients whose test was positive, that, and leaving aside, I know the uncertainties about exactly what the positive test meant, but did you only tell the patients who had tested positive? Did you also communicate the test results of those that were negative to the patients?
Well, I must have told the patients who were negative that they were negative. Surely, I mean, I don't remember, but I must have done.
Can we look at BART 0000675, please? So this is the document that we had been looking at for a different purpose a moment ago, the meeting of the 22nd of May 1985. Could we go to the second page? We see at the top of the page, it says, concern was expressed about the confidentiality of personal details of HTLV3 antibody-positive patients. No lists are circulated to avoid the risk of misuse by unauthorised people. And then this, all patients will be informed of the result of their HTLV3 antibody test on request. And then it goes on to talk about being counselled on the implications of a positive result. Now, this doesn't appear to suggest an intention within the region automatically to tell every patient. It was left to patients who didn't know they were being tested to request the result.
I mean, to the best of my knowledge and belief, I went through all the positive tests and informed all of the patients in due course that their result was positive. Now, that's not an easy task, and it would have taken a period of time. And I think you've got another letter, which you may want to show me, which fleshes out the bones of this discussion to some extent. But it was never my intention to withhold the results of anti-HTLV3 tests from my patients. And I don't believe any patient ever said to me that they thought that I had done so.
But are you able to explain why these minutes of a meeting which, it was a regional meeting, obviously not exclusive to the London Hospital, but a meeting you attended, records that patients will be informed of the result on request, and then it goes on to say, I didn't read this bit, that doctors and dentists responsible for the care of positive patients should be informed of positive tests. So there appears in this to be automatic provision for telling treating doctors and dentists of the result, but patients will only be told on request.
Well, I'm puzzled by this note myself, because I find it hard to believe that there was a policy of telling people their results as, on request, in the sense they had to come and ask me to deliver those results. It doesn't make sense to me.
Because that would be possible if they didn't know they were being tested in any event.
I agree that's possible, but I mean, when I look back on the 40 or so patients who were positive under my care, which will not actually be the number who seroconverted under my care, because I saw a lot of patients who had been seroconverted elsewhere. So I don't believe that I ever heard of or saw a patient who said, Dr. Colvin, you didn't tell me about my HTLV3 positivity or HIV positivity. I just didn't, to the best of my knowledge and belief, it never happened.
Can we look at the letter that you may have just been alluding to, Dr. Colvin? It's BART 00000535_001. So this is a letter from the 16th of April 1985. If we go down, we can see if we go down to the bottom, we can see it's from you. It's dear colleague, and it's attaching a set, I think, of recommendations. But in the last paragraph, you say this: I now have anti-HTLV3 results from many of the home treatment patients. So that may give us an idea of the timing. This is April 1985. I'm reluctant to give the list wide circulation because of doubts about the meaning of the test and the sensitive nature of the information. And then you say this: by no means all the patients who are positive have been told the result of their test, though I have not hidden the information from those who wish to know. If you need to talk to any of them about the AIDS problem, perhaps you could give me a ring to discuss the latest position. Can you explain that sentence, by no means all patients who are positive have been told the result?
Well, if we go to the second paragraph, secondly, I have issued a set of guidelines for the management of haemophilia in general. It goes on to say, this is also rather parochial, but you will note that we are treating all samples from patients with haemophilia being high risk and are attempting to deal with difficult problem of providing adequate dental care for our patients. Then the paragraph, I think above, sorry, I need to, can we go back to the main letter? Sorry, I was choosing the wrong paragraph. Thirdly, and perhaps most importantly, not importantly, most importantly, I have given all our home treatment program patients a new set of home treatment rules, together with some counselling on the AIDS problem, and virtually all of them have now been spoken to. So I think what this means is that I had a discussion with all the patients at risk, would have discussed whether they wanted to know about their situation and about the AIDS problem in general, and would have provided them with information. Now, clearly, autonomy would also dictate that if a person didn't want to know the results of the test, then they could refuse to have it. But I don't remember anybody ever saying such a thing. So I think you need to take these two paragraphs in together.
Let me see if I've understood that, Dr. Colvin. So the paragraph you've just drawn attention to is to say you think you've spoken to all the home treatment patients, or virtually all of them, it says, have been spoken to. It is clear from the next paragraph, the sentence I asked you about, that there must be some patients who have not been told the result of a positive test. reading them together, is your suggestion that that's because they may have not wanted to know?
I don't know. I mean, I've only seen this letter this
I know.
morning, and I'm very surprised by it, because my memory is, and I repeat it, that all the patients who were anti-HIV positive as a result of the testing process were told of their results and were counselled and were involved in their care at a complete level. And I would never have dreamed of not telling patients about their results. It doesn't make sense to me.
Okay. And can you recall if you communicated the results of the tests at specially arranged appointments? So for the 40 or so who were positive, did you bring forward their routine appointments to speak to them relatively urgently, or was it at the next routine appointment?
I think there probably was a mixture, depending on whether perhaps when the appointment was coming up. But I would have thought most of the communication would have been taking place outside the clinic, because I mean the clinic itself is not a good place to have those sort of discussions. So I can recall one or two of the conversations, but not many of them at a specific level. But I think that I would have seen patients separately. But I can't confirm that. And I can repeat that nobody under my care ever said to me, "You didn't do that properly."
And in terms of the counselling or information that was provided, what, as far as you can recall, at this stage in 1985, what kind of information do you recall you were giving your patients who were tested positive?
Well, that was obviously a long-term discussion. I mean, you can't just do the whole thing at once. And what I recall is that I assessed the situation, produced an information sheet on the subject, and then gave them that information sheet, which hasn't appeared in the papers. I didn't have a copy of myself, but there's no doubt there was such an information sheet, and that was given to patients to explain to them their situation and the precautions they needed to take. So there was no formal counselling at the time. It was down to me. But I did prepare a document. Even my nursing staff, there weren't that many nursing staff at that time. We were still very short of nursing staff. So whilst I relied on my nursing staff, it was my job. And I believe that I fulfilled my obligation by giving them the information and giving them the leaflet, and then continuing to see them to the best of my ability with the counselling I had available to me.
And did you advise and warn as to the risks of sexual transmission?
Yes, of course.
Were tests offered at that stage or at a later stage to the partners of the patients?
Many partners were tested, but exactly when, I can't recall the detail, but there's no doubt that partner testing did take place at my centre, although, as you know, I've said in my statement that sadly one of my patient's partners was infected, but that mine was not the only centre where that happened. And only one person was infected.
One partner?
Yes.
And then in terms of the numbers who were infected with HIV, you've set those out in your statement. If we could just look at that, it's paragraph 63. I'll just put it up on screen as well for ease of reference. It's WITN 3343007, Henry, and it's page 21 of that document. And we can see it's paragraph 63, bottom half of the page. As of September 1987, source personal educational lecture series. A, severe haemophilia 31, moderate/mild haemophilia A 9, haemophilia B1, von Brillenbrand disease 0. The children is not there identified. How many, I don't know if you can recall an exact number, but approximately how many child patients were infected with HIV?
Okay, I had 3 patients who'd been to Lord Mayor Trelawney College, so they were shared care, and I didn't have really any influence on the treatment they had at the Lord Mayor Trelawney. I know you'll be discussing that at a later time. So those 3 patients were all anti-HIV positive. There were 3 other children that I can immediately remember who, 2 of whom eventually died in adolescence of AIDS, and one of whom died of a head injury in early adolescence. Those are the patients that I can remember.
So 6 children, 3 of whom were Trelaw's children.
I think that's the case,
who were
but of course,
infected with HIV.
one of the problems that I identified for the inquiry is that, first of all, there's the definition of a child, and then secondly, there's the definition of when the childhood begins and when it ends, and when the infection takes place. So it's quite a complex question, which I found very difficult to answer. But I believe, as far as I'm aware, that there were 6 children under my care who were anti-HIV positive.
And is that number subsumed within the overall total here, which is
Oh yes,
41?
it's included within.
And of those 6 children, and again, without asking you obviously to deal with any individual by name or particular circumstances, do you recall whether those 6 children, or any of those 6 children, were they all severe haemophiliacs, or were some of them within the moderate or mild group?
At least 5 were very severely affected, and one of them, the one who died of the head injury, may have been moderate rather than severe. And by that I would mean a level of, say, 1 or 2% factor rate as opposed to less than 1% factor rate. So the answer is that all 6 were really severely affected.
And then you go on to say in the statement that some of these were patients, this is how I'm reading what you said in your statement, please correct me if I'm wrong, Dr. Colvin, some of these were patients whose treatment was shared between you and an associate centre.
Yes, and some of them were patients who had come to me already infected, but this is 1987 now, so that some of them were patients who'd, for some reason, arrived in Whitechapel already infected. So it might be that somebody came to Whitechapel for, or at least to London for university. It might be that we had another immigrant community. There was one patient, I'm not sure he was 87 or not, but suddenly one day arrived in Whitechapel, an African refugee with no English, who turned out to have appalling haemophilia and was also HIV positive. Although curiously, he wasn't hepatitis C positive, so his HIV positivity must have been transmitted either sexually or by blood transfusion, because if he'd had concentrated, he'd been HCV positive as well. So how to manage a patient who arrives on my doorstep with no English, who's got a terrible haemophilia and is HIV positive, is, if you like, for you an example of how difficult our lives could be.
Is it fair, however, to assume that the majority of the numbers listed here were patients who were being treated at the London hospital or one of the associate centres within the region at the relevant time?
That's likely for the majority. The point I'm trying to make is that the 41 patients were not all mine exclusively by any means.
And if we just go over the page, please, to paragraph 64. What you've said there, and this was in answer to a question about where work was done to establish dates of seroconversion. You said the timing of infection was studied using stored serum samples. The result was that it was possible to determine the probable location and even date of infection fairly accurately in a number of patients. And then you talk about patients often wanting to know the site and date of infection, but given significant movement between centres, many of them could have been infected at any centre they'd attended. I'm not clear from that, Dr. Colvin, whether work was done at the London hospital to, at some point after you got your initial results in 1985 or thereabouts, to do effectively what you've just told us was done at the Royal Free, and to look at go back and test.
Yes, we did. Yes, we did.
Your statement doesn't tell us what the outcome of that was.
The outcome was that some patients, particularly perhaps the Lord Mayor Trelaw patients, had been seroconverted very early.
And what about the bulk of your patients?
I don't recall.
In what form, if you can answer this, was that information collated? In other words, if the inquiry wanted to try and find that information, where would it have been?
Well, when these tests were done, I wrote out a cardiac system, which I described in my statement, and I believe that in that cardiac system are records of most, if not all, of that look back, if you like to call it that. And when I retired, I gave that cardiac system to John Passy or Dan Hart for safekeeping, and I believe they've kept it. But it would be very difficult, I think, to go through every single patient's notes to find out. I think that would be the best source.
Okay, thank you. And then, sorry, I haven't put your statement away. There was something else I wanted to ask you about it. You say, I think, somewhere in your statement about 2 patients being infected at other hospitals. So, as I understood it, was 2 patients under the London Hospital's care, but whose infection was elsewhere.
I mean, there were a number of patients of mine who could have been infected elsewhere, and sometimes I knew they had been. I think one of the points I wanted to make, and maybe relevant, is that patients understandably wanted to know where they'd been infected, and yet for me, it wasn't. What was much more important was to look after them having been infected, rather than to spend a lot of time working out exactly when and where they'd been infected in a way that wasn't necessarily going to help their care. And so for me, it was much more important to look after my patients than to worry about exactly where they'd been infected, because many of them, or some of them, had been infected outside my care, but I didn't care for them any less because they'd been infected away from my care.
Were there any patients in respect of whom you were able to establish that their infection had been not at a haemophilia centre, yours or associate, but at another hospital, for example, receiving emergency treatment in an A&E department? Did you have any patients that fell within that category?
Yes.
What, if anything, without revealing any identifying details about any individual patient, what, if anything, can you recall about that?
Well, this is very difficult because you've just said that you don't want to identify a patient. Of course, I can comply with that to the best of my ability. But I will, if you wish, try to tell you a story that is de-identified. Would you like me to try to tell you a story that's de-identified?
Yes. If this assists Dr. Colvin, what we're interested in is examining if there were, as it were, systemic failures or systemic problems which led to patients with haemophilia being treated in circumstances where they wouldn't necessarily have received that treatment at their haemophilia centre. Dr. Winter gave us 2 examples of that, and I'm just...
And do I have to reveal the centre in which they were treated?
The hospital, but nothing else for present purposes.
Well, I mean, if I identify the centre at which the person was treated, he can always certainly be identified fairly easily by the inquiry or by the people who are listening to this discussion.
That would be possible to be identified simply from naming a hospital?
Yes, I think it would.
Well, in that case, what I may ask, we can perhaps ask you to give that information in the form of a supplemental written statement on that issue later. Are you able to tell us anything about the circumstances in which patients with bleeding disorders became infected, not at haemophilia centres, that doesn't identify anything? Well,
I think what I'm going to try to do is to, if I may not mention the centre itself at the moment, I may mention it at a later time in private or in a witness statement, but I can give you an example of something that happened which is important. So a patient comes to London for educational and professional purposes. He's a young man who's got relatively mild haemophilia. He has had an injury, a sports injury, and he's treated and develops HIV infection. He is understandably deeply upset by that. And I spend many, many, many hours with him and with my nursing staff trying to manage his distress and his clinical circumstances. Some years later, he becomes mortally ill, and my haemophilia nurse and I are told about this one morning, and we drive over 100 miles to try to reach him before his death, and he's unfortunately passed away when we arrived there. I tell this story really to illustrate the terrible nature of what was happening, and I tell it particularly to describe his resentment at the fact that he had been infected in a way which he thought was completely unnecessary. Now, I'm not in a position to judge whether his infection was unnecessary or not. I wasn't there at the time when he was treated and infected. But I do know that he deeply resented what had happened. And I can understand that. But the point that I was making before was that I wasn't sure that that deep resentment necessarily helped him to manage his situation. And that my job was to do my best to help somebody in a position which was, of course, intolerable and terrible, and which I and my nursing staff spent many, many hours trying to resolve. And it cut to the heart of what we were trying to do.
If we look at one further document, Dr. Colvin, it's BART 0000509. This is a document that you've seen enclosing a confidential list of patients who are under our joint care whose anti-HTLV3 results are known to me. And then appended to this are, by reference to different associate centres, lists of patients, dates of testing, and the result. Is this the means by which you were communicating to the directors of the associate centres which of their patients were HTLV3 positive?
Obviously, I can't recall this letter. When it was sent to me, I was very surprised because I didn't remember ever having seen it before. But when I looked at it, I was able to see that each of these separate centres had been addressed, and that I think you're right. This was the means by which I communicated the anti-HTLV3 results to the associate centres, and it relates a bit, as I've pointed out in my personal statement, to the letter which you, or the minutes that you've already referred to, and I put that in my personal statement. Now, my belief is that by this time all these patients would have known of their status, and I believe it was my duty to share with my associate centre directors the information I had, for many reasons, including the reason that at the time we were regarding samples as hazardous, and therefore they needed to know, partly for their own information about how to treat these patients as they appeared in their hospitals, and also partly to know how to deal with their samples.
So just in terms of timing, is it right to infer from this 27th of August 1985, by this time or around this time, you would have completed the process of the testing, at least of the patients that you had identified as being potentially at risk?
Obviously, I can't prove that, but I believe so.
Can we then just look at a couple of further documents on the issue of providing information to patients? BART 0000674, please. And if we go to the third page, we can see under the heading halfway down the page, HTLV3 antibody positivity. Sorry, I should have said this is this is November 1985, 27th of November 1985, and it's the North East Thames Region Haemophilia Working Party again. We can see here what's being said. It was stressed that informed consent should be obtained before patients are tested for HTLV3 antibody, and wherever possible, counselling should be offered prior to testing. Now, this is regional rather than simply limited to the London hospital, but this would seem to suggest that there were still, at least regionally, patients who had not yet been tested.
Of course, it's possible. I can't be sure of this.
Here it's being said that their informed consent should be obtained before testing.
Yes, and indeed, I mean, there were one or two patients who we realised, even in the late 80s, had been at risk that we didn't realise had been at risk, had been lost to follow-up, and somebody would come to the hospital and my nurses and I would say, good heavens, this patient is potentially anti-HIV positive. And then we would, of course, get their consent before testing. Because the testing without consent was really confined to that period, I think, of crisis in the latter part of the very end of 84, early 85.
Well, can we just see the follow-up minutes to this? So this is saying informed consent should be obtained before patients are tested for HTLV3 antibody. And then if we go to BART 0000673, I hope this is the right reference. We can see so we can see the date is 25th of June 1986, so this is the middle of the next year. Again, it's the same working party. You're present, Dr. Colvin's Dr. Kernoff's present, and others. And if we go down towards the bottom of the page, we can see it says amendments of the minutes of the last meeting, 27th of November 1985, and then under HTLV3 antibody positivity, it's suggesting that the minutes should be amended to read, informed consent should be obtained if it is possible or reasonable to do so before patients are testing. So the rather more absolute position that was articulated in the minutes in November does not appear to represent, in fact, the policy of the region, which is you obtain informed consent if possible or reasonable.
Well, minutes are of course, the only record we have of these discussions. They don't necessarily... No minute necessarily gives an absolutely accurate view of what was decided. That is a sad fact of minutes in general. But this is quite an interesting example of where it's not quite clear what a minute perhaps meant. Even a very definite minute may not have meant exactly what it was said to mean in the minds of the people who were present at the meeting.
But what we can see is in the middle of 1986, so away from that crisis period
Yes.
that you've described, the position that's being articulated, presumably on mature reflection, because you're taking the positive step of amending a previous set of minutes, is to say it's not always obtain informed consent, it's obtain informed consent if possible or reasonable to do, with no guidance as to the circumstances in which it might be possible or reasonable to do.
I can understand that, but I mean, I think by the middle of 86, I mean, we're now well into that period. I would expect that if I needed to consider an anti-HIV test or anti-HTLV3 test, I would have thought I'd have obtained informed consent to get it.
Now, in your witness statement, Dr. Colvin, let's find the paragraph reference for you. So it's paragraph 56. Henry, it's WITN 3343007. And if we go to page 19. So we see towards the bottom of the page in paragraph 56, you are addressing the issue that I've just been asking you about over the last 20 minutes or so, Dr. Colvin, about the process of testing patients for HIV. And then if we go to the next page, what you've said there in the third, actually, before we get to that, in the first paragraph, you refer to Professor Zuckerman being particularly interested in the search for the NANB virus, which is not in itself a controversial statement, but you say that in the context of a discussion about the retained samples. Were the samples of sera that were retained at the London made available to Professor Zuckerman?
Well, I think there was one particular occasion when one of my patients had a nasty attack of clinical non-A non-B, when I must have discussed this with Professor Collier, probably, and he said, well, Eri Zuckerman is particularly interested in looking for the source of non-A non-B hepatitis. May we share this sample with Eri? And Eri wrote back to me initially saying he thought that he'd made a big advance in the search for the virus, and in fact, he later said that he hadn't. And of course, it was during this time, and we just heard from the Nobel Prize-winning material recently, that British physicians and pathologists were indeed searching very, very hard for the virological cause of non-A non-B. And I think I accepted with Professor Collier the idea that this particular acute attack of non-A non-B over a patient of mine might be looked at by Aries Zuckerman.
And would you have told the patient that?
I shouldn't think so, no.
And then we go on to see, you say, you refer to an emerging discussion in stimulating a considerable divergence of medical and medico-legal opinion as to whether further consent for anti-HIV testing was needed. And then you go on to say this culminated in the GMC guidance of 1988. And I think we perhaps should just look at that because we haven't looked at it in the hearings so far. Henry, it is NHBT 001 0410, please. So the first page is a press notice, May 1988. If we go over the page, we see the GMC's paper that it put out. There are a number of matters relating to HIV and ethical considerations, which I don't need to trouble you with, Dr. Colvin. If we could go to paragraph 12, please, Henry, which should be the bottom of the next page. If we pick it up in paragraph 12 under the heading consent to investigation or treatment, what's there said is, it has long been accepted and is well understood within the profession that a doctor should treat a patient only on the basis of the patient's informed consent. Doctors are expected in all normal circumstances to be sure that their patients consent to the carrying out of investigative procedures involving the removal of samples or invasive techniques, whether those investigations are performed for the purposes of routine screening, for example in pregnancy or prior to surgery, or for the more specific purpose of differential diagnosis. A patient's consent may in certain circumstances be given implicitly, for example by agreement to provide a specimen of blood for multiple analysis. In other circumstances it needs to be given explicitly, for example before undergoing a specified operative procedure or providing for a specimen of blood to be tested specifically for a named condition. And then if we go over the page to paragraph 13, testing for HIV infection, the need to obtain consent. The Council believes that the above principle should apply generally, but that it's particularly important in the case of testing for HIV infection, not because the condition is different in kind from other infections, but because of the possible serious social and financial consequences which may ensue. So, pausing there, Dr. Colvin, you're right, I think, to point out that this is the first publication by the GMC on this specific issue, and it was in 1988. But would you accept that the GMC is not here saying anything new? It might be speaking for the first time on the issue, but it's saying the long-established principles of informed consent apply.
Of course, the long-established principles of consent apply, but I don't believe that it was ever the case that there was ever any other particular investigation which absolutely required specific patient consent. This was really the first time in 88 that this had been suggested. I referred earlier to the role of the haematologist, that is, being both a physician and a pathologist. So if I was sent a patient for investigation, then I would decide which investigations to perform. And when I got the results of those investigations in my laboratory, I would then choose what further investigations were to be performed to solve the problem. Now, all that has a continual flow of information, of course, and it's my responsibility to choose the right tests in the right circumstances. However, there may be another instance where that chain of flow has been broken, and then it will be necessary to go back to the patient to ask for consent to continue a separate investigation that now became apparent. But the reality was, I think this was partly the mindset of haematologists, that we felt that we were physicians who were also pathologists who had the task of solving problems. And we believed, perhaps incorrectly, that we did have the kind of consent that we required to undertake these investigations to solve an urgent problem. Now, I can see there may be those who disagree with that view, but that was the view I think that we had.
these were samples, as I understand it from your evidence earlier, that they weren't samples that had been taken back in 1979 and stored since then. They were samples because you were using them for the purpose of finding out whether the patient was currently infected. They were the samples that would have been taken at the last appointment.
Yes.
So for most of these patients, they're likely to have been samples that would in fact have been taken in the course of 1984.
Possibly, yes.
I mean, possibly
Yeah.
1983,
Yeah.
but no, most likely 1984. At which time you may not have had, in June 1984, to pick a date potentially at random, you wouldn't at that stage have been able to test for HIV, but you would have known that testing for HIV
Sure.
was something that was being investigated. How could it be said that a patient's giving informed consent to the use of their sample for testing for a virus that no one's spoken to them about?
I mean, I understand what you're saying. I'm just telling you what I think was in our minds. What was in our minds wasn't necessarily appropriate. I mean, I personally don't regret what we did. I mean, maybe I shouldn't say that, but I really don't regret what happened. But the position was that nobody explicitly said that HIV testing had to be done with informed consent until much later.
I think you have previously made a number of observations at invitation about the lack of UK HCDO guidance on certain issues. Can you recall whether there was anything that emanated from UK HCDO at this time, either in the meetings or in any communications on the issue of how to go about the process of testing?
No, I can't. I mean, we had a look at something a while back, I think, which just said everybody ought to be tested for anti-HLV. I mean, we've had that discussion yesterday, I think.
Yes, so, but on the specific issue that you're talking about being whether the patient's consent should be sought in advance.
I don't think, although I can't prove, but you're in a better position to judge than I am, I don't think that UK HCDO gave a view on that. But I don't actually want to spend all my time blaming UK HCDO for the things that happened in our practice. I mean, I recognise that UK HCDO couldn't tell us exactly what to do about everything.
And then just dealing with some issues of consent and information and testing more broadly. We looked yesterday at documents which showed the programmes of testing that would be undertaken at routine appointments in relation to liver function, with some tests being undertaken more frequently depending upon the outcome of first sets of tests and so on. I'd just ask you to assist in relation to the information provided to patients about that process. Again, if we're talking here typically late 1970s, early 1980s, so I'm asking you now about before HIV was on the horizon in 82 and 83. What information do you recall giving or think you would have given to patients about the reasons for taking samples of blood from them?
Well, I think we would have told them that the liver function tests that we had were not always normal, that the outcome of those abnormalities was unclear, and that we needed to continue to monitor their progress or lack of it. And
given that the practice, as I understand it, of taking a sample of that was then stored for potential future use was a regular occurrence. It wasn't something that you did new in 1984.
No, sure.
Did you tell patients that you were doing that you were taking a sample that was not going to be specifically tested for liver function tests and but would actually be stored potentially for future use?
Not that I know of, no.
Before we come to look at testing for HCV, which we can do after lunch, there's just one small point which will require us to look at two documents quickly that I wanted to ask you about. And that's about providing information about patients to third parties. So if we look at HCDO 0000177 underscore 010, this is just an example. There are lots of other examples from lots of centres about information that was provided to Oxford. This happens to be January 1984, and we can see it's from you to Ms Spooner referring to the register details and making a number of comments about specific named patients. And we know that information was regularly provided by centres to Oxford for the purpose of inclusion on a register. What did you tell patients about that process, if anything?
Nothing. The policy was very clear that from the 1960s, the UK CDO record had been on a named patient basis, and the data that we had was transferred to Oxford. The result, of course, was that we had the best database, as I think I mentioned, in the world, for knowing who was where, what they were being treated with, what their details were, and what was happening to them. Now, I've seen this, obviously, you've given it to me, and it doesn't surprise me. That's the way it was.
And I think we know we'll come on to this afternoon. It was an issue that then reared its head again in the 1990s at various UK CDO minutes. I'll come on to that.
At this time, it looked completely routine to us.
And then just one further document before we break, BART 0000543 underscore 004. So this is a letter, January 1986. This is you sending data to Dr. Krask. If we just go to the second page, please. So we can see it's from you. If we go back to the first page, we've obviously concealed the names, but you are here sending Dr. Krask at the Public Health Laboratory in Manchester information, data about named individuals, their HTLV3 result and the date of it. Now, again, I understand why that data was being collected by Dr. Krask. We see it from the UK HCDO minutes. But did your patients know that their test results and names were being supplied to Dr. Krask?
I don't believe so, no.
I think that probably is a convenient moment, sir, to break for lunch.
It looks like 2 o'clock then that we'll meet again. So 2 o'clock, if you please.